quite nice that you're here because chronological age is the biggest risk factor for age-related diseases. So I think really looking at where you spend time is quite important. And of course, it should not only be the chronological age, but also what you are doing. So I'm really driven and I'm standing up because I have passion for health span rather than lifespan. And I think I really like the field moving into the healthy lifespan extension rather than 10, 20 years ago. It was all about lifespan, and I would say death was the enemy in the room, and I don't think that should be the case. I think if we can afford and democratize what we are doing, that everybody is healthier for longer, this would be great. I have a couple of disclosures. I'm working lots with Multipharma. I'm working at the NUS, leading there the Center for Health and Longevity, but also have some sidekicks. I just opened a longevity clinic, G Longevity, in February as a founder in Singapore, and now we are going abroad. I'm also with G3 Health, which is more for the B2B services, annual health screenings to make them better, that we will have exposure to better annual health screenings. And I'm the Chief Medical Officer at NU, and I will show you some of the things we are doing. And I'm very glad that now also healthy longevity or health span is going globally, that we are living at this moment in time in the United Nations Decade for Healthy Aging. I think this is important because now we can give KPIs to countries how they should actually evolve their agenda, political agenda, that health is affordable to everybody. So that's what I'm doing. And I will also talk about the Health Longevity Medicine Society. I start with a slide I think always I start with because it reminds me what I did, I would say, wrong as an internal medicine specialist and a clinician scientist in the last 20 years in my clinical practice. I always got patients and they asked me, "Doctor, do you have good news or bad news?" And that's a very dichotomous question, and I always had an answer and say it's good news or it's bad news. I always gave, yes, it's good or it's bad. And we were always neglecting, I would say, that there is a trajectory of our health until we have a disease, and that's depicted here in this slide. So our organ performance is going down with the chronological aging process. And what we are doing in clinical practice, and I wrote lots of guidelines in my life, we always said, okay, once that certain value is hit, then you're a disease, then you are my patient. And otherwise, go for it, I will see you later. And maybe next year because you had an annual health screening. So that's not good. So we are dichotomizing our body, whereas we knew, and I did so much research in these trajectories and cohort studies and doing lots of epidemiologically, that we knew that the function is going to decline. So I think lots of countries are now really trying to enable services to rescue individuals who are at the edge of becoming a patient. And I would say we call that prevention. Think about a 70-year-old having a little bit higher glucose level, higher HbA1c, at the edge of becoming a diabetic. And what is the GP saying? I would say very often, eat less and move more. And of course, we have all these guidelines. We tested these guidelines too, and just giving a folder is not changing the needle. So I love what Zoe is doing to really try to change in an evidence-based way behavior of individuals. What I really try to achieve is even of individuals who are normal, to say, okay, normal is not good enough. How can we optimize your health that you have the least propensity of an age-related disease in 10, 20, 30, or even 50 years' time? And I think what we should try to avoid, just looking at individuals who are already aged, I think even I am a little bit too late because I see my aging process when I look at the pictures as the previous speaker and see what kind of changes I have. I think we should start much, much earlier. Think about the 20s and 30s. So this is what we are doing in health and longevity medicine. We are really trying to optimize individuals. And I would say we should not neglect that we have the chance even to improve the health of generations to come by improving the body of the individuals who want to become pregnant, who want to become a father and mother. And I think that's really the next step in the field. So I came to Singapore. I was recruited to say, okay, can you change the health of individuals living in Singapore, and can you increase the health span by 3 years and 10 years? They didn't say they gave me a contract for 10 years, so I'm not sure I signed the contract in the end. But Singapore is really trying to change the needle to give health to individuals. Why? There are 2 points. First of all, the fertility rate is very, very low. It's a 0.7, which means like we have no children. Now, of course, not no, but there is a demographic shift. Secondly, individuals in Singapore, they are living super long. We are one of the longest living nation, 84.3 years. So it's always Switzerland or Japan or Singapore. But people age not gracefully. The health span is very, very low. There's lots of diabetes, cardiovascular diseases, etc. And understanding that is super interesting at this moment in time. So Singapore has a problem, and that's the reason why there's lots of investment. And while creating, together with Prof. Brian Kennedy, the Center for Health Longevity, we said, okay, we have a preclinical group. We are looking at zebrafish and C. elegans and Drosophila, etc. Of course, we have mice and rats. And then we link everything together with the clinical group I'm heading to really see in phase 1 studies to phase 4 studies how we can change the needle. And creating the evidence, in the end, to bring that into clinical practice, what we now did, and bring that into public health. So within our capacity of still being small, we are not an entire university of just working on health longevity, but steeply growing. We really try to keep on the transition and to have the feedback loop. So once we find something in animals, we bring it back to C. elegans, etc., etc. I'm very proud that we actually jumped into clinical practice, and I think this is also a little bit the reason why I was invited. So it's not only that on the private level, we now have evidence-based, and that's very important for me, health longevity medicine clinics, but we also opened for the first time on Earth, the first longevity clinic in a publicly funded hospital at the 31st of August this year with the members of WHO and the World Economic Forum, really showing, okay, we try to bring it to everybody who is living around that hospital and changing that. Very important, we have 2 arms. We are looking at diagnostics and we are looking at interventions. I think they really are very close together because first of all, it's unethical to not have the interventions to bring it into clinical practice. But I also need, for the interventions, I need the right biomarkers. And I think that's at the moment at the edge, or we are at the edge, to really understand what it means and get this clinical feeling, what you can apply and what not to apply. And I will show you some examples. Very important, I think this is the super limiting factor I have to really explode in research output, etc., is education. We need staff who are, first of all, trained to implement whatever we think it's evidence-based already, but also trained staff in research. So very often I'm now headhunting at different departments, but then I have individuals who have no understanding yet about the aging process. And I think really investing into education is very important. That's the reason why just 4 months ago we started the Academy for Healthy Longevity. Very important also in the education that it's not only that we have to educate Singaporeans, laymen, but also healthcare professionals and scientists, but also really globally move into a field which is health longevity medicine, which is evidence-based, which is recognized, and we are basing it on frameworks. Because at the moment, I can call myself a health longevity medicine society. The first question you should have to me, why can you state that? And that's right, because I cannot state it, because it's not defined, there are no guidelines, there's no framework. If I'm going to the medical board, they will laugh at me because it's non-existent. So that's the reason why I founded the Health Longevity Medicine Society. You have a beautiful council, and the first thing we defined, what is health longevity medicine? That's optimizing health and health span by antagonizing aging processes across the lifespan. So that's very important. The most important thing we would like to achieve in the next coming 3 to 5 years is having healthy longevity medicine recognized within internal medicine. We think that's the good motherhood in normal public services, which means that if you want to subspecialize as an internal medicine specialist, you can choose for geriatrics, what I did in the past. I'm a geriatrician, but you can also choose for healthy longevity medicine, or you can then become an endocrinologist, etc. So hopefully that will be the case. If you want to become a member, we are very open. We have international case sharing sessions where one clinician presents a case. It's a lot of learning at this moment in time internationally, so please join. You can use the QR code. So what do we do in healthy longevity medicine, and how do we apply? That's the topic I'm talking about today. How do we apply these kind of biomarkers? So on the left-hand side, you see what kind of phenotypic characterization we do. So you see the biological, clinical, and digital phenotyping. On the right-hand side, you see the therapeutics we're doing, what kind of lifestyle interventions we are doing, supplements, but also environmental changes, for example, our interventions. So very important, we have the biological, clinical, and digital phenotyping, and there are lots of examples, and I think there is no recipe at the moment what you should do and what not to do. We had a case discussion, and thereafter a panel discussion, just asking longevity medicine physicians, what do you do? Do you listen to your heart? Not to your heart, but to the heart of a patient. And so it's not defined, and there is lots of discrepancy what people do and what not to do. But I think the clinical phenotypic characterization is, for me, at the moment, the most valuable. Patients are coming to my clinic, they want the biological clocks, they want to know how old they are. I would say that's fine, I give it to them, and I am learning, but I would rather like to know what is their ApoB level, how good is the VO2 max, etc., etc. So there's a huge amount of testing, and I think we are really in the learning phase. Very importantly is the digital phenotyping. 18 years ago, on my Falls clinic, I implemented the first wearable device, accelerometer, to actually detect what people are doing. Compared to then, now, what amazing information we are getting out of it. So that's the reason why always people get devices, or they already have devices that we can track the physical activity, their sleep, even sometimes the dietary habit. We are working with a couple of apps to actually validate them. So it's amazing what additional information you can actually now have, if of course the patient agrees, to really fine-tune the interventions. Most importantly, let's go back, and what is a biomarker of aging? Because we have heard so many very nice presentations about it. I think first we have to define it. And our Biomarker of Aging Consortium is now active for less than 1 year. It's not the first birthday yet. And we already have a couple of papers, because everybody is struggling with the same, what is it really? So the first paper was, okay, how do we define a biomarker of aging? So it's a quantitative parameter of an organism that either alone or in a composite predicts biological age, and ideally its change in response to interventions. Okay, so huge components in there. So it's a quantitative parameter, so you are quantifying. Of course, quantitative is also dichotomous, but what we really want to do is a continuous parameter, which is hopefully sensitive to change. It can either be one factor, so it doesn't mean that we have to have the composites. If you think about, and you heard lots about epigenetics and CPZ sites, these are all composite scores. If we just find one, it's enough, but very likely because of our complexity, looking at the physiology of our body, it will be many. So I think it's a composite of lots. And ideally changes in response to intervention. That's what I want as a clinician. I want to see that it improves. I can look at yellow fingers. Of course, yellow fingers are the best to predict what? Lung cancer, because you are smoking. We can now also use the methylation age. Okay, that's perfect. I would rather ask them, but never ask for the weight, measure it, because everybody is under or overestimation that. But it's very important that it's sensitive to change. And we have the molecular, the physiological, and the digital biomarkers, and you see all the omics approaches in this finger. Very importantly, so first you have what you can measure, and that's how are you going to apply that. And I think that the three gray ones are very important. So I have predictive biomarkers. So a marker which is predictive, like the yellow finger, predicting your mortality. But then you have responsive biomarkers, which I love. So you have an intervention and you have the change. But what is the real beauty I think we should all hunt for, especially if we want to implement that in clinical practice, are the surrogate endpoints. So you have the intervention, the change, and that change is also associated with outcomes we are looking for. So I would say the clinical space is looking for these kind of biomarkers. You have heard about the UK Biobank already. It's a beautiful source of data because of the magnitude of the numbers of individuals and what's in there, and the long-term follow-up, and that's accessible. And I can tell you that's not for granted that so many cohort studies are there and you can make use of it. So if you want to have a career in epidemiology and biomarkers, please have a look at it. It's quite accessible. So we asked the question, because I wanted to have something for my publicly funded clinic, can we make clocks just on variables we could have and every GP could measure? So what did we do? We looked at all healthy individuals in the UK Biobank. We looked at all variables every GP and principal could measure, and that's given on the left-hand side. And we made a body clock, and we made organ-specific clocks. And of course, we first, as you already heard, we first generated a first-generation clock, predicting the chronological age, and then the incidence of all the diseases we have, and of course, also mortality. And it's published, this paper, in Nature Medicine. So, and we looked at the body clock, incorporating all these variables, and that body clock was quite good in predicting in healthy individuals who would have an age-related disease later in life. And for example, as you see here, stroke, diabetes, cardiovascular disease, etc. And at baseline, in predicting the incidence of a disease 6 years later, these individuals were biologically using this body clock. Every GP could already implement predicted the onset of the disease. But we also were quite interested in, okay, if you need all the variables, can you reduce it by making organ-specific clock? There's an incidence of a disease in that specific organ system. For example, you have the cardiac clock. Is that cardiac clock predictive for the onset of a cardiac disease 6 years later? And you see it here. There are lots of results in this slide, but everything which is green is significant. If it's more red, it's more significant. And what you see is that organ-specific clocks are very good in predicting a disease in that organ and not so much in the other ones, which is of course logical, but the body clock was the best one to predict an overall incidence of disease. So there we decided to go ahead with the body clock and also to validate that now in GP data sets, especially in Singapore. But what we also did, and I think I was a hospital manager a long time, I skipped that part a little bit now in my life because I really want to again focus on research and hopefully really implementing health longevity medicine in most of the hospitals on Earth. We looked at the interaction of organ decline between different organ systems within one individual and then over time. So you already heard a couple of data there that in the previous course by Ricardo, that our organs might have a different pace of aging, and therewith there is a certain incidence of an age-related disease in individuals. So our question was, if one organ is going to decline in the first 6 years, no disease, but just a decline, how is that associated with other organs who are they declining from year 6 to 12? And can we do, while applying a network analysis, can we make sense out of it? And that's what you are seeing here in the slide. What you see is no disease in these individuals, but if the pulmonary function is not stable, but is going down in individuals, it's very likely that their cardiac function is also going down in the next 6 years. However, not the other way around. If the cardiac function is going down in an individual, pulmonary function is very unlikely to going down, which means that we now understand And if you can call it pace of aging, it's different organ systems, I don't want to argue. But we now have a sequence of what's occurring, of course on population level, but within individuals, looking at all the organ systems, to, I would say, to structure healthcare a little bit different. That we could say, okay, this individual with a pulmonary function going down should be referred of being tested for the cardiac system, for example, but not vice versa. And I think with lots of researchers, we are now at the edge looking at data differently, which is then making, hopefully, a real change is how we refer, how do we actually use the cost we are spending in healthcare systems. And I love the different paces of aging, I would say, in organ system, but it makes it also very, very complicated. It's very complicated, I can tell you, to use biological clocks in clinical practice. That's also the reason why I'm part of this company new, where we really apply systems biology using whole wide genome scans, the microbiome analysis, lots of blood databases, lots of proteomic databases, bring them together for our clients to really crunch the data who you are. And of course, who you are, we only have lots of data, and we are trying to make sense out of it with machine learning, etc., and then giving personal advice to these individuals. So these are just my data. So I'm very lucky that lots of colleagues shared their biological age. At this moment in time, I just had dengue, so I'm not sure if that's the reason why I'm just 3 years younger. But I can tell you my glycan age at that point in time was also super poor. I was much, much older. But I think already knowing what your genome is, what your microbiome is, what your glucose levels are measured continuously makes so much sense to make choices in the end. And this is what we would like to provide with, especially on the biological side, having all the data, and now implementing also lifestyle data to hopefully make a difference. We are open for customers since a couple of months in the Netherlands, and now also in the UK. I use these kind of approaches, biological approaches, in the journey in the longevity clinic. So we have lots of testing, and we are specifically looking at the clinical testing. As I already said, including a VO2 max, resting metabolic rates, etc., etc. We are upgrading our individuals to really connect them to our dashboards to get all their physical activity monitoring systems in their sleep patterns, etc., CGMs, etc., etc., and crunching then the data. And I can tell you it's not perfect. I don't think it's reproducible because it depends on lots of clinician crunching the data, but spending lots of time hopefully giving the best advice. We are focusing at the moment on the biological markers, and I just show you here a case in our dashboard. So you see an individual, male, British Indian, 56 years of age, a fund manager, married, no medical history. He wanted to know, give me my biological age. I said, oh, sir, I think not possible, because what do you want to know? Which organ would you like to focus on? What do you really want to know? So he did the entire assessment. We are applying many more than 5 biological clocks, but we released these 5 biological clocks to him. A Seno clock, which is based on blood biomarkers, a blood age by our own company, epigenetic age. With what I'm saying, epigenetic age, we analyze the data based on 8 we can do it by 8 clocks. Very important is you should not apply every algorithm to the data set. If, for example, somebody is 80 or somebody is very, very young, because you have to look at where certain clocks are validated, so where it makes sense to apply them. So that's very important. But we came to the conclusion, especially if we are giving the clocks, that we are not giving 4 to 6 epigenetic clocks, but also in research we are giving the median of 4 of the clocks, because as you already heard today, some are good in predicting diabetes, some are good, more predictive in mortality, and we do not know which one is the best. So it's a little bit risk-spreading, and that's the reason why we take the median. Glycan age and the microbiome age. But what you see here is like, this is one individual with one age of 56, but the glycan age is 36, and then we have this epigenetic age being so high. So what do you actually tell this person? So we now do studies to actually see how can we give these kind of data to clients and how to receive that. Do they understand that we are looking at very, very different biological systems within their body, and how should we give it? I, as a clinician, love to have all these clocks because all these clocks have a different meaning for me. In the end, it's not a clock, but it's a biomarker of aging where I can hopefully interfere. And I will show you some data. I think a very difficult situation at the moment in the field is also that everybody defines optimal differently. I just show you in the table on the left-hand side that if I'm applying a clock optimal age and a new one, that the definition of what is optimal of, for example, a liver function or creatinine is very, very different. So that's the reason why within the society, we are now defining how do you get towards optimal ranges and how do we define that. And it can be that it's ethnicity, sex, and age-specific. We do not know yet, but there is now consortium work. So if somebody would like to join, please do so. So all these together, especially with the clinical data sets, I'd have no time to show you, gets to an outcome of assessment. And what we do with our patients, we are stratifying them by organ systems, as internal medicine specialists do. And then we define on the interventions. And there's lots of granularity because in these layers of brain, cardiovascular function, metabolic, et cetera, et cetera. I would like to touch a little bit in relation to the biomarkers of aging, to the interventions. I will only give you two examples why I think that the biological clocks of the biomarkers of aging are leading towards certain interventions. And I will show you a couple of RCTs. So I will focus just for the last 3 minutes on supplements. I did lots of studies on nicotinamide mononucleotide. You might have heard it. You can buy it on Amazon. I see lots of photos here. It's very funny. If we're talking about supplements, everybody makes a photograph. So hopefully you don't take NMN. You only should take NMN if you really need it, and then it might help. But nicotinamide mononucleotide is a supplement, and very often people take it because NAD levels are going down with the chronological aging process, and if it's going down, then the mitochondria are not working well. You have a higher risk of age-related diseases. If that's causal or not, we do not know. But there's a huge amount of evidence that, first of all, something goes down, and that's NAD level, and you can supplement it with NMN. So that's great. It's a little bit like you have a glucose level you're measuring, and you give insulin. So it works quite well, and I show you the data. We did a randomized control trial, 4 arms, giving NMN to healthy individuals. That's what I'm striving for, to optimize them, at the age of 50, in just 60 days. So we had placebo, 300, 600, and 900. And you only get here the clinically, I would say, meaningful outcome parameters. And that is the 6-minute walking test and the blood age clock and the SF36, which is a quality of life marker. But most importantly, and that was the primary outcome in this RCT, are NAD levels going up? And yes, luckily. So the NMN was good. At 300 and 600 and 900, the individuals who got it had a higher NAD level. And what we also showed, but absolutely, look, this is a small randomized control trial, absolutely not powered, but a secondary outcome parameters, clinically meaningful parameters, the 6-minute walking test, and the SF36 was the best in the 600 milligram and was equal to the 900 milligram. So, which also means we need many more of these studies to see how much supplement you should give, because 300 was not enough, we think. Because also if you look at NAD level change, and that's on the left-hand side, you see there is an NAD level increase, but not as much as 600. So we asked the question in a post-hoc analysis, and think about the analogy of you giving insulin and you're measuring glucose, and then seeing, of course, hopefully a good result. Can we do the same with NAD levels and NMN? And if, with the hypothesis that we should increase NAD levels, do the individuals, the participants with a higher NAD level increase? Do they also have better clinically meaningful outcomes, like measured in the 6-minute walking test and the SF-36. And yes, it's the case. Especially, you need at least roughly 50 nanomole per liter increase in NAD level. And then you have potentially the highest chance of a clinically meaningful outcome parameter. So what does it mean? We are now going into an arena, like in normal medicine would do, that we are titrating supplements based on an outcome we can measure. There are lots of problems with NAD levels and how accurate they are and how reproducible they are, but this is the entire thinking now in health and longevity medicine to make it really evidence-based. Like we are manipulating the body with certain interventions, and we want to know, with hopefully surrogate markers, that it actually changed and there's a positive outcome parameter. And that's the reason why I'm really arguing, do not just either take yourself supplements, but measure first, know what you need, and don't prescribe it so much, like if you don't know what to do, to clients. So we now do an accurate study where we're really titrating NMN levels and NAD levels based on NMN and some other supplements. We do the same for alpha-ketoglutarate. It seems that alpha-ketoglutarate is manipulating epigenetics. So at least we know epigenetic changes occur after taking alpha-ketoglutarate. So we do the ABLE study where we only select individuals who are epigenetically older, using 4 clocks and using the median, compared to their chronological age. We're giving for a couple of months 1 gram of alpha-ketoglutarate, and at the primary outcome, again, we want to see that these clocks are sensitive to change and that the biological age is lower. This is the first trial really applying these epigenetic clocks as a selective parameter, but also as a primary outcome. And we also now do that in studies where people undergo major surgery. We are super interested in finding the best food on earth for individuals, also looking at the microbiome, etc., and especially looking at what kind of food groups or foods have the most potential, for example, at senolytic, of being senolytic. Senescent cells accumulate, how do we get rid of them? And we do that for many other hallmarks of aging, just as an example. But I think it's exciting that we could manipulate the body just with food, which we already heard from the Zoe talk. So closing down, because I'm really running out of time, I think education is the key. If you would like to be part of our educational programs, please look at the NUS Academy for Health and Longevity. We just had our first incubator, inviting from around the world youngsters to just from very early morning, starting with Tai Chi and yoga and kickboxing, to really late at night without alcohol. It's not allowed on the campus. To be with us 10 days on the campus, and I think we really made an epigenetic change towards the life of these individuals. We haven't measured it, but it was massively successful. We are doing it again in June next year. And the last slide, if you are really interested in health and longevity, use the QR code. We have an intensive course for 3 days at NUS end of February, and then we have a 2-day conference just on one topic, and that's supplements, where we really showcase the preclinical knowledge, the clinical knowledge. We are summarizing everything in meta-analysis, really showcasing what it is. Regulators are included, and then we are defining the next stages for research, but also clinical implementation, and clinicians have case reports. Thank you so much.
Thank you so much.